Inaugural series, Dr. Heinen's helped save the best for last. Dr. Heinen probably doesn't need much of an introduction, and is a graduate of this residence, in case you didn't know. And Dr. Heinen is a board certified family medicine physician, sees patients in our Belltown clinic. Dr. Heinen's clinical interests include people of all ages. She has additional expertise in LGBTQ care, HIV medicine, and women's health. She leads the Trans Health Ally group of primary care providers at UW Medicine. Dr. Heinen sees and appreciates each patient as an individual, considers it a privilege to be able to serve them. She believes in providing excellent care that's respectful and compassionate. Welcome. It's so wonderful to have you here. I'll let you take it. May allow people to filter in. So the thrust of my talk today is to really unite the two ideas of medical competence for LGBTQ plus care, and also connecting with our patients in a way that allows us to be effective advocates for their health. I bring to this three lenses, and one is one I share with many of you, which is as a primary care provider, I am so pleased when a patient brings their A1C down to an excellent range, or when their panic attacks are a distant memory that are now well controlled. My second lens is that as a lesbian, as a patient, and the times that I have been able to appreciate that a provider is looking at me through a very glazed over part of their Johari window, where it's clear to me that they don't know what they don't know. And the most important lens I bring to this is my 30 years of experience with pretty much every type of queer patient there is, and bringing their experiences to life. And that's actually one of the most important things I'm going to talk about today, because it is a path toward connecting with our patients and also, again, for promoting them. So part of this is kind of a narrative, bringing some of those stories, or at least experiences, into a summation for people to appreciate. And so one of those things is the idea of the patient experience versus listening to the experiences of our patients. Talk about the minority of stress model for those of you who are not familiar, and how we can help turn maladaptive into adaptive coping mechanisms for our patients. Realizing that medical competency really requires that we have an approach to the patient that allows, again, that kind of connection where the patient can trust us and we can understand their experiences, but also the essential kind of typical medical basis of knowledge on essential preventive care, optimizing mental and sexual health, and many of the other realms that are so important for people's health. And although certainly, obviously, in an hour, I'm not going to cover the true essentials of LGBTQ plus healthcare, I want to at least kind of do a summary of an overview of the essentials to build on. And so Nick and I are already collaborating on thinking about how to further develop the residency curriculum. I definitely won't be talking about a 101 on sexual identities or any gender affirming care, which those of you who have listened to me talk before, you're like, wow, she's not talking about gender affirming care, or things like, immunization schedules or in the weeds, sorts of things like that nature. Now, I've been doing this care for 30 years, and I'm going to be a bit provocative and say, have we really come a long way? When I started my career, 40% of homeless youth were LGBTQ+, and that's still true. The annual rate of HIV incidence is 32,000 people per year, down from 50,000, although that's still not enough of a progress given all of the tools we have now. But unfortunately, more people who have new cases are BIPOC, and that's not progress. There are many more people now, as we'll discuss, who identify as bi+, which is a category that includes pansexual and bisexual people. And that group has increased dramatically, but our knowledge base is still very limited. And we really need to try to have a better grasp of what's important to their health. And facilitated by the current milieu, hate crimes are on the rise, as documented by the FBI for all LGBTQ plus people. Unfortunately, there was a 35% increase from 2022 to 2023 for transgender and gender diverse people. Now, this idea of the patient experience has been a little bit corporatized, continuing my provocative stance here. And by which I mean, it's a little bit about, oh, wait times or how is your parking? But I'm going to say that the patient experience is much more important than that. And over my career, I have seen that a lot of providers think that if they tolerate LGBTQ plus patients, that's sufficient, right? But really, we're going to try and take that step further to have people have an understanding of the experience again of our patients. And this comes naturally, right? This is a superpower of family medicine and primary care in general, is that we are always focused on the individual with an understanding of the larger issues. And so I'm not famous as Michael Ballant, but my quote that I made when I was a third-year resident in this program was, every interpersonal interaction is a cross-cultural experience. And the reason I say that is we walk into a room to talk to a new patient and immediately, marvelously, we assess very quickly their expectations, their fund of medical knowledge. Of course, there's the usual language barriers or isms that we carry and we're trying to address, in addition to, trying to understand what the patient may not know about their own health and their own internal struggles with coming to the physician, right, or provider. So yeah, we're pretty awesome, I say. And we really need to have this understanding of that every interaction is unique, because for when it comes to LGBTQ plus care, there's quite a number of letters in the acronym if we really dig down. And each is a unique subpopulation with its own flavor. Not to make this seem undoable, but that's just an important thing to get. I have in bold here all of the terms that are going to be required by the Washington Administrative Code to be in our electronic health record under the SOGI, sexual orientation, gender identity, smart form, that patients can either fill out in my chart, or we as providers will be now helping to facilitate getting this information into the chart, because there are percentages that need to be met by certain time frames. So you'll be called to arms in order to bring some of this into play. And again, I'm having this mostly as self-explanatory, but I do want to point out that there's genderqueer when it comes to EPIC, but in reality, queer applies to those sexually and gender diverse people who define themselves that way. We really just have to ask people what they mean by that. It's sort of a definition that is undefined on purpose. And then for those of you who are not familiar, which many of you are, two-spirit identities are people who are indigenous, does not apply to anyone else. And it's really another coined term that unites the many words that have been used across time in North American tribes, each has their own individual language, to capture the role of people who are either of a third gender or gender fluid or gender variant, and their role in their community. So it really is intrinsic to people who play this role in their community. There are people who are Lakota and a gay man, and they're not necessarily a person who has two-spirit. Of course, I'm not telling anybody what they are, but just to have you understand that this is really about the community. Now, intersex is not on our list for the Washington Administrative Code, but of course, it's very important that we understand those that care. And I'm not really addressing that today, but it's very important. And then asexual, I will talk about. And at the bottom, I have the other categories that are in the SMART form, as again defined by the Washington State Hospital Administration from the WAC. So we often talk about LGBTQ plus community, and I always kind of joke that this acronym mostly has in common that these are all letters of the alphabet, right? These are very different groups of people. But there are some things that are definitely shared, and one is that there's a shared stigma, and it relates to having personal attributes that are so close to the sexual orientation and gender identity that for those of us who, those of population who do not get it, they think that this is not natural, even though it's been part of the human experience for as long as there are written records. And so it really is natural. But this stigma has created experiences of trauma and loss for many, not all. We don't want to assume this affects everyone. But when it occurs, it can be very profound and cause people to lose their support systems, their family of origin, their church, their community, their job, many other things. And this, of course, affects a person's socioeconomic status. If they don't have a place to lay their head, they have their physical safety very much affected, and on. And the emotional trauma is sometimes, of course, the greatest burden that people carry. When people are devalued by society, and this is not specific to LGBTQ plus populations, that can be incorporated into self-concept. And that sexually marginalized really can foster self-harming behaviors we'll talk about. One other interesting feature is that there's a random distribution of people who are queer. They're like sprinkles in the ice cream of life, right? Every zip code, every nationality status, and religion and geographical location. And so that speaks again to the human experience, but it also very much means that there's not really a community unless a person has the resources to go out and find a community, and especially youth and seniors are most at risk of not having that community. But also, of course, for people who live in sparsely populated areas or certain geographical locales within our country, it's harder to find community. Being throughout the population also means that many people are multiply marginalized. And so they can have sort of cumulative effects from this marginalization, which is the concept of intersectionality. But of course, there's things that are really not the same for many of these groups. So sexual identity and gender identity are very different things, very different cultures. There's health risks particular to certain groups and not as much in others. There are very different abilities to avoid detection in public. So when it comes to transgender women, they are more at risk from a public safety standpoint, especially when they're in a transitional phase. Financial circumstances are very different. Again, this is where the intersectionality comes into play, but gay men are generally have a higher income than people who are gender diverse, and there's an interspersing, and of course, again, very individual experiences there. Just speaking from, again, a 30,000 foot view. And then there's coming out as a sexually diverse person versus transitioning as a gender diverse person. And so when you come out, you can do it at your discretion, you can control the circumstances more, and some people never do. As evidence, there was a recent person who had died who, I think he was a military person who came out in his obituary and talked about all of the things in his life that he would have done differently. Whereas if a person transitions, this is a big ongoing project if people medically transition, which not everybody does, but even socially transitioning with the legal documentation, right? That's a big job. And so, those are very different experiences. Unfortunately, gender diverse people right now are kind of in the bullseye of culture wars, partially to do with lower numbers, partially to do with fewer people know that they know transgender people, which people don't know often that they do. And also because sexually diverse people have just had a little bit more time to garner some of the rights in our society. So this is a really difficult time for gender diverse people in our society. Now, everybody is affected by the minority stress model, which was actually originally coined in 1981 about lesbians, and then the model was developed talking about gay men in 1985. And this is a quote from the 1995 article, updated with more inclusive language. And it talks about when people are subjected to chronic stress related to being stigmatized, it has effects. Of course, there's other models that are very similar about other marginalized groups, but this language is specific to queer people. And it talks about how there's really three stressors. One is the internalized norms that people have taken in and turned against themselves, like homophobia and transphobia against themselves. There is the anticipated, the expected stigma that people experience. And then there are the actual experiences that people have, which we'll talk about, are very significant. So I'll delve into the consequences of that in a second. But when it comes to stigma, people have a very good reason for anticipating these possible episodes of rejection and discrimination. So in a study done by the Gallup organization in 2016 to 2018, the TransPop study, it was called, it talked about people's experiences in the previous year in the healthcare milieu. And this is gender diverse patients. And the purple parts of the bars are people who are BIPOC, and gray are people who are white. So this has that intersectional flavor to it. So 2/3, so the first one is 2/3 of BIPOC transgender patients and almost half of white patients experienced discrimination from a healthcare provider in the past year. And that was broken down as things like being intentionally misgendered or misnamed, refused care, being treated abusively, either physically or otherwise. And naturally, that translated into people wanting to avoid care due to fear of discrimination. And I know people who have died of heart attacks or who never sought care for their thyroid cancer because they would rather die than be humiliated in the healthcare world. And of course, when it comes to preventive care, that's more optional. So the rates of not coming in for that care is even higher, but that has lifetime echoes on people's effects, on people's health. So just know that when people come into care, we think we have a welcoming, sunny clinic, all focused on the positive patient experience. But for many of our patients, they really feel like they're walking into a fire, with good reason. And so understanding that in and of itself is one thing that I would say would separate true allies from people who, mean well, but are not necessarily getting the experience of LGBTQ+ patients. Now, maladaptive coping is the same in different, again, marginalized groups, not specific to LGBTQ+ people, but there are things like not coming prepared, not taking care of a person's self, and then substance use, high-risk behaviors, including sexual ones, eating disorders or obesity, suicidality, and intimate partner or sexual violence. These are all very common expressions of people's stress. And we all know from all of our patients during the pandemic, how many more people got into trouble with alcohol, right? This is a human response. But our goal as primary care providers is to try to help people aspire and implement adaptive coping mechanisms. And many of these, of course, are already being used by people. For instance, on an individual level, when it comes to LGBTQ+ folks, people, if they lose their original family, they create a family, people who they like and have something in common with. Humor is definitely a positive coping mechanism, but just know that sometimes people use it and they're incongruent or they're minimized their pain. Developing self-advocacy skills, very important. And then accessing personal strengths is another adaptive coping mechanism. Like some people, lesbians in particular, are often athletes, at least at one point in their lives. And then I will say across the board, when people come out or transition, it is a positive for mental health outcomes. Now, turning this whole minority stress model on its head, there's also a minority strengths model. And really try to see, like, how do we use these adaptive mechanisms? What works to help people move toward more positive health behaviors? What was found was that people had social support, again, often created, and consciousness of their community. Those helped to form identity pride. And those three things kind of in concert and individually helped inform having better self-esteem, resilience, better mental health, and more positive health behaviors. On a community level, adaptive coping includes a lot of reframing, right? So things like pride and fabulous and gay, those were all conscious reframings. They're not spontaneously kind of jumping out of people's souls. Reclaiming words like queer. Not everyone can use the word queer, and it's no longer a denigrating term. Creating community, of course, is key. Not available to everybody though, so using the web has been a real help for a lot of folks. And then providing mutual aid has been something that may not necessarily be known outside of the community as much, but it's very powerful, especially during the HIV pandemic. Kind of a necessity thing has been developing political awareness and presence, and HIV was the thing that really fed ACT UP, which is sort of the model of, really in-your-face political advocacy that has been required at times to help promote health. And I will say that in my experience, and don't want to speak for everybody's experience, and this is very local, is that many patients are really much more likely to get their COVID immunization if they're queer. They're more likely to use other mechanisms against other infectious diseases if they're at risk of HIV. As compared to some of my straight cisgender patients who are going to step back and think about that for a while. So let me just give you an example of both sides of the coping coin. Okay. This is a patient who I just met a couple of months ago at the HIV clinic at Harborview where I work. So Mike, I'll call him, is in his 50s, he's gay, he's in a long-term relationship, and he's very self-deprecating. He came to the United States when he was 8 from the Philippines and was abused physically by his stepdad and then was sexually assaulted in the Marines. So he sees psychiatry for helping manage mood and PTSD. He's not dealing with substance use. Now he actually works at the VA as a counselor for other people, for vets who have PTSD, right? So he has these skills that he has developed. But what's really important is that we learn to acknowledge, and sometimes it's hard because we hear things that are so hard. And even an ouch, or wow, that must have been so hard. Even if you can't go into a full understanding of everything he's gone through, really is powerful. Too often, we as providers step back and are sort of mute, and be cerebral observers. It's not helpful to our patients. Behind the humor, which he was just coming fast and furious with all kinds of humor, and so I was kind of balancing between acknowledging the pain and also trying to play banter with him with some of the humor. But he hasn't been doing his self-care. He hasn't been in for his HIV care in too long, and his prediabetes care he completely forgot about. And he offered, that when he was in the Marines, he was like the most hard-ass drill sergeant in getting people to do their exercises. And so in a way, he was, showing a path forward for himself. And so I encouraged him, and this is a trauma-informed principle, encouraged him to utilize his clear strengths, but to apply them to himself to try to overcome his trauma. And so I'm going to see him again in a few weeks, and we'll see how things are going. So what does medical competency in LGBTQ plus care look like? So as I made clear, it really means understanding a person's experience and trying to come to things from their perspective. From a classic medical standpoint, we want to understand some things about population health, some relevant knowledge about screening, and then specific skills when it comes to education, prevention, and treatment of many important domains. Population health, this is again from Gallup. Every year they query people, how many people in the United States identify as LGBTQ+, speaking of adults. And this last year, 7.6%. Similarly, the Census Bureau in a pandemic era survey queried the same question and found out that in our state, it's about 10%, which may not be surprising for people here. But what is alarming and surprising to some people in our society is that the rates of LGBTQ+ identification have really gone up in Gen Z and sequentially before that, generation by generation. And I think some people are thinking it's a social contagion. Now, I grew up in a place where I was surrounded by, this is tongue-in-cheek, heterosexual propaganda all the time. And I didn't even know of queer people, right? And I still had an unshakable sexual orientation. So I don't think it's a social contagion. my but there, and by the way, a lot of that change has been mediated by more people identifying as bi and pansexual. But what I can tell you quite clearly is that there aren't as many baby boomers around who are queer because we died. And you may think I'm being a little bit dramatic, but it's true. And in fact, just 2 months ago, a true population health study was published. This is very rare for people who are queer because these questions are usually asked in broad, pan population studies. But the Nurses Health Study 2, one of the classic population studies, was published, and it showed that bisexual women died 37% earlier than heterosexual counterparts, and lesbians 20% earlier. Now, these are nurses, highly educated, knowledgeable about medical care, not under as many socioeconomic stressors as many people in our society. And the comment was, that despite the fact there wasn't a lot of racial disparity in the query, they don't have significant numbers on that because it's kind of a homogeneous sample. And yet these numbers show up. And when this was previously published in 2004, it showed twice the rate of alcohol and tobacco use in sexual minority women. But even for women who were never smokers, if you compare them, the bisexual and lesbian women to heterosexual counterparts, those trends in mortality are the same. And so in the paper, officially they're saying, well, bisexual women have 50% higher rates of hypertension, and this may have something to do with allostatic load, which we are still in the infancy of understanding, right? And certainly when this study started in 1989, those were not things that were being measured. If you look at the newspaper article about this study, when they talked to the researchers, we're like, this has to do with toxic stress. Now, this is, again, a study with beautiful Kaplan-Meier curves. And, we don't have that kind of a study for the gay men or baby boomers, who is the subject in this study. But we know that cohort was hollowed out by the HIV pandemic, right? The numbers have got to be worse. And oftentimes it's the fact that these questions are not asked that is the most telling thing of all about, LGBTQ health is not important. One thing that's been very hard to ascertain is the rates of HIV in people who are transgender and gender diverse. So if you look at the CDC website, you will not find transgender, it's just sex assigned at birth and sexual orientation to this day. But there was a study published in 2019 where it took all of the 88 studies and did a meta-analysis to try to write at the best numbers they could. They were highly weighted, the studies that had lab values, et cetera, and came to the conclusion that there's a prevalence in transgender women in the United States of 14% of HIV, and trans men 3%, way higher, of course, than background. And this prevalence in part relates to employment discrimination and survival sex groups over time, which, there were higher numbers in this group. And then we throw in the intersectional ones. 44% of Black transgender women in the United States are HIV positive. These are ghastly numbers. Latina, 26%, white, not quite 7%. So again, not to be too passionate, of which I've been accused of in the past, but these are so telling. So now on a lighter note, okay, this is definitely tongue in cheek as well. We look at suicidality. We can see that suicidal ideation and suicide attempts are very much greater in folks who are gender and sexually diverse. So again, I'm not going to go into the bar charts in detail, but the first two bars in each cluster are cis women and men who are sexually diverse. And then the third one is transgender individuals. And again, just look at suicide attempts. The background rate of suicide attempts in the United States, and this is lifetime suicide attempts, is 4%. And throughout major studies in transgender people, it's 42% or about 40%. And of course, higher still, still significantly higher than baseline in folks who are sexually diverse. And then this slide is not meant for anyone to memorize any numbers, but it's to make a point. Okay, so this is the Youth Risk Behavior Survey, which has followed these sorts of trends for many years. And this is 2019 to 2021. And if you look at sexual identity and sexual orientation with the purple arrows, that's people who are female at birth. There's no gender identity query, at least for the data in this slide. And this looks at the prevalence of attempted suicide episodes that required medical attention, right? So that is, you know, a fairly high bar that we're looking at. And if you look at identity, bisexual youth were much more likely to have these numbers, you know, almost 9% versus 3% for lesbian girls and the 2% for heterosexual. And then the telling thing here is if you look at behavior, those who are sexually active, and by the way, identity and behavior don't always overlap. That is where the rates were really high, like almost 14% of people who had same-sex or both-sex partners, again, assigned female. And these are all teens, basically. It was interesting, not having sexual contact was protected. Same story, slightly different in those who were assigned male at birth. Again, identity by and young male individuals, at least by assigned sex at birth, had much higher rates by identity. But again, behavior was really the predictor of when people had more suicide attempts. And I bring this up because it's a very important public health issue that is often overlooked, that this triad of the three elements of sexual orientation are very important. So we always talk about people's identities, right? But realize that there's a lot of patients you have who may have behaviors that they're not even discussing because they don't let it in or let it out that they have these behaviors, but they are even at higher risk often. So for instance, in the youth risk behaviors survey from 10 years ago, if you look at bisexual girls, they not only had higher rates of heroin use, they also didn't wear their bike helmets or wear their seatbelts, right? So these are, when I say risk-taking behaviors, it's because people don't value their own lives. That's part of that internalization. Different topic. Again, not very many population studies. When we look at cancer risk, there is a huge database in the UK where they ask people, and this, by the way, is all people who've had a cancer previously, and now follow more cancer. Okay, so that's not necessarily the general population, but it's got a very good N of 131,000 people. And so if you look at these numbers, there were some surprises that no one had ever come to before. Now, for the record, the gold bars are extremely rare. So lesbian, and these are all cisgender, lesbian and bisexual women had higher rates of mesothelioma, but very few cases. The null point, by the way, is breast cancer. So we break down the most important parts of that. The oropharyngeal cancer rate, odds ratio of 3 times heterosexual women was completely unknown previous to this study. Endometrial cancer was suspected because there are higher BMIs more often in sexual minority women. Nobody knew about higher rates of pancreatic cancer in Hodgkin's lymphoma in bisexual women, not in lesbians. So is this allostatic load? Who knows? But understanding this information might be a way that we get clues into mechanisms and treatments and prevention, right? So this is important for everybody for us to be paying attention. And contrary to many patients and even some providers still, that's a God help us kind of look, cervical cancer is equally prevalent in lesbians as in heterosexual women, and there's an odds ratio of 1.5 for bisexual women. And yet, patients and occasionally providers still don't understand that HPV vaccines are as important, maybe more important, in sexual minority girls. That same study with an N of 188,000 looked at gay and bisexual cis men. Not as many surprises here, but it did kind of quantitate the rates of virally mediated cancers. And so Rosie's sarcoma, anal and penile cancers were more common. And often this, of course, related to people having HIV. But now there is a population-based study called the PRIDE study. So anybody who's in this demographic, I invite you to sign up for this because this is how we get important information about this population. So I'm going to intertwine the approach to the patient and preventive care because, as I said, it's the only way to be an effective primary care provider, right, is to have people take our wonderful advice. And so I'm going to just kind of float through this, and I'm going to give everyone the slides so that you can have this, you can refer to it if you like. So for, again, I'm speaking of cisgender people now, lesbian and bisexual women often think, well, this provider doesn't know much about me, not necessarily wrong, but they're also afraid of being judged if they come out. So they may not share, again, behaviors or identity. And always, of course, our superpower is asking open-ended questions, right? Who's in your support system? Who do you live with? And I can do what I call open-minded education, because I don't want to be seen as preachy, although could be. And so I say things like, this may not apply to you, but let your friends know that no woman's body really can tolerate having more than 2 drinks a day over time and not have health consequences. Or you may already know this, but you know, smoking increases the risk of cervical cancer. And as a lesbian, you have as much risk as anybody else, not just heterosexual women. And so that's my kind of stealth approach to trying to get people to get the information without acting as though I'm being judged. They're all the same, of course, concerns as everybody, but there are some that show up from folks who have maladaptive coping mechanisms, which is not everybody. But for those who smoke, you know, cardiovascular disease, and people who are overweight may do have higher rates of arthritis. That's been shown in studies. There are higher rates of asthma, which is attributed to an increased allostatic. There's depression, anxiety, and PTSD at greater rates, and I have seen dissociative disorders. I don't know that that's a study, but that is a thing. Often in people with a history of abuse. Interpersonal violence rates are actually higher for sexual minority women than those who are heterosexual. HPV and VD are very efficiently shared between women. Even HIV has been. HS being chlamydia can be, which is the chlamydia, so it's a bit of a surprise here, but it's the thing. There are higher rates of Hep B and C, again, more often in people who have used substances. And a thing that you may not necessarily intuitively know is that when you have women, and even self-identified lesbians have had sex with men, of course, but also bisexual women, when they have sex partners who are men, again, speaking in a very binary, you know, gender traditional way, they are more likely to be bisexual and thereby maybe connecting to a higher risk sexual network. So we want to tap again into positive attributes. I'm not going to go into these, and help people get to places of adaptive coping. Like for the lesbian paradox, where there's lower rates of diabetes than you might think, because again of a history of athleticism in some women who have sex with women. Created families really help. And one great thing about, I think this is pretty true across the acronym, is that people talk about recovery and about seeing therapists. You know, it's part of the coming out process maybe that they've gotten good at. So that's a positive. And so when we talk about screening, we think about cardiovascular screening is again officially the same, but we want to be thinking about this allostatic load, and we definitely want to think about keeping people connected to care so that we can monitor this carefully. Think about screening for diabetes for people who are overweight. And then when it comes to cancer screening, again, there's no official differences, but know that there's this information around the edges. When you look in someone's throat, who's a woman who has sex with women, really look at their throat. I've had 3 women with tonsillary cancer in my practice over the years. Nobody else, only the 3 lesbians. So don't forget HPV vaccines. And then screening for depression, of course, and substance use is important for all of our patients. The osteoporosis screening is not changed in this one. Now, in the medical care setting, for gay and bisexual men, again, cisgender, a lot of people are wondering if the provider really wants to know everything. Or on the flip side, they're afraid that that they're only going to be judged by their STI work and not anything else. And so they may not be coming forth with information. And so that's why our non-judgmental stance is always so important. Take care of all of our patients, right? So again, those open-ended questions are so important. And open-minded education in this group are things like, you probably already know this. It is so easy to get syphilis through oral sex. I have patients who I tell this and then a year later they don't remember that I told them that. I'm trying to get the word out that, gonorrhea resistance to antibiotics is really going through the roof. Again, medical concerns are all the usual ones. The cancers we talked about, diabetes is higher in gay and bisexual men. And for those who do have HIV, which is not everybody, currently the best guesstimate is about 1/6 of gay and bisexual men in the United States will have HIV during their lifetime. But there's a lot of chronic illnesses that come with that infection. In addition to depression, anxiety, and PTSD, a lot of people have social pressures and their higher rates of eating disorders, which may not something that, again, intuitively springs to mind. We'll talk a little bit more about substances, about sexual health, but the substances and sexual health intersect for gay men in club drugs, and there's a whole realm of chemsex, or again, a small percentage, but something to know about. And then I'm going to talk more about sexual behaviors and risk, but we always want to ask about behaviors and not assume, because I have many patients who haven't had sex for years who are gay men and feel like that someone is reducing them to their reproductive organs if we're focused on that, right? So, and again, many of the same potential positives and adaptive coping mechanisms. I will say some of my gay and bisexual men are the most adherent to care of anybody. And maybe that's a selection bias because they're the people that survive. I don't know. But it's a strength and helps their health. So screening here, again, there's no official change in the guidelines, but know that if a person is HIV positive, now anybody who's over 40 should be on a statin. This is a recent study that came out last year. Again, thinking about eating disorders, a digital rectal exam is a good idea annually per the CDC. The United States Clinical Task Force doesn't have an opinion on it. There's no guidance yet on timing when you would start it, but anal cancer is high enough, especially in those who are HIV positive. And so not necessarily for prostate health, but to check for areas of induration or lesions. Immunizations, again, that's in the schedule. Screening for depression and substances, so important. IPV is actually not as common in gay men as in heterosexual men, but higher somewhat in bisexual. And then, I just wonder if people are on PrEP, tenofovir disoproxil for decades, it does affect people's bone density. Could that be a concern eventually? Now, asexual people, many of you are probably have dealt with, and the main point about their care is that this isn't a pathology, it's about 1%, and people really resent being always asked about if they need contraception and STI screening. That isn't to mean, though, that people never have sex, right? So it's a very delicate dance, and it certainly wouldn't cause us to modify their risk of cervical cancer screening. So I try to finesse that by saying, well, HPV is a neighborhood virus. You don't have to have intercourse to get HPV. And, it's just even a one-time exposure. So I try to respect people's stances and identities while also making sure they get the screening that would be ideal. And then for transgender and gender diverse people, it is key to remember that there are high rates of trauma, as I spoke about. And so that's why we want to really double down on making sure we're being respectful for using names and pronouns, using the person's language for anatomy. There's a way to document that in the SMART set. That's my little pro tip there. And always remember, for all of our patients, we want to elicit and not assume their needs. So not everyone's going to go through medical transition. We want to see where they're coming from. And being transparent about how things work is another trauma-informed principle, so important for all of our patients, but it's maybe especially gender diverse ones. So this is, trauma-informed care in a nutshell. Enhance a person's sense of safety in your care. And again, in addition to the usual concerns, heart disease and ischemic stroke may be higher. PCOS is higher in transmasculine individuals, and so they might have a tendency toward cardiometabolic risk. Osteoporosis, I'll talk about in more detail. Sometimes eating disorders can figure into dysphoria for folks who are gender diverse. Here's the substances that people are more likely to use, actually less likely to use opioids than the general population. I have like a summary again of what's needed for sexual health surveillance. So again, these slides are kind of a primer, just to let you know that that's why I'm going to be sharing them with you, but I'm not going to go everything in detail. So the basic rule for trans cancer screening is if you have the organ, you screen it. But I have my finesse points on here. So a person's transmasculine, been on T for more than 6 months, it's going to be very uncomfortable to do a speculum exam. So we lean on doing HPV screening first. And if a person hasn't had a chest masculinization procedure, of course, they have the same screening guidelines. But even those who have, they still have some breast tissue, chest tissue is the preferred term. And so, just making people aware that that's still there, and let me know if there's something that comes up, if there's anything that's more firm there. No increase in endometrial cancer, but not impossible even in people on long-term T. No change in risk in colon or ovarian cancer, which is also true for trans feminine individuals. There's no increased risk, probably a decreased risk of prostate cancer, but it's not gone. And even if people have vulvovaginoplasty, the prostate is not removed. So we know that it is still there and sometimes easy to forget. For breast cancer screening, the same as cisgender women, unless they start estradiol, pretty close to being around 40, then maybe delay for 5 years, depends who you listen to. There's no official guide. There is a very low rate of benign brain tumors that are more common in people who are trans, especially prolactinomas and meningiomas in trans women, and somatotrophomonas, which is growth hormone secreting pituitary adenoma in transmasculine individuals. But those are like vanishingly small, but different. And again, there's no official changes in cardiovascular screening, but if people are on testosterone at higher doses, of course, their lipids may change. We want to be aware of that. And if they've been on T a long time, we want to use the male calculator for statin consideration. Definitely for trans feminine individuals who have risk factors for any kind of atherosclerotic disease, they should be on transdermal estradiol preferentially because it has a lower risk of creating issues for venous thrombosis. And I have found, again, this is a superpower, that when people transition, sometimes they are willing to take better care of themselves because I point out to people, you have something to live for. You are now becoming your authentic self. And that message has really worked for some of my patients. And when it comes to depression and anxiety screening in this group, there was actually a very complete, if you're interested in this detailed, this study is so interesting. Anxiety and affective disorders are more common, but things like schizophrenia and bipolar disorder are not. And the key determinant is having social support, not surprising. So again, we kind of want to make sure that when I have people going through transition, I actually try to ask them every time about their mood, because sometimes it's better because they're transitioning, and sometimes it's worse because they're getting blowback from people around them about the fact that they're transitioning. There will not be a test on this slide. This is for your reference. But it just goes to state that if people have had a gonadectomy and they haven't been on hormones for some reason, they are really at risk of osteoporosis. And so you can follow the flow chart at your leisure in an individual patient. And when it comes to sexual health, I want to just point out the nomenclature here for a second. Many of you are familiar. So there's W and M, or cisgender, women and men. Transgender folks get an extra letter. And then S is sex with. So if a slide says WSTM, that's a cisgender woman who has sex with a transgender man. And so sexual health relates definitely to the behaviors, but also to the sexual network, as I mentioned before. Very important. And then there are biological factors that are specific, especially to transgender folks. We know, of course, that folks who are anal receptive have higher rates of HIV transmission And also there's vaginal fragility and vaginal dysbiosis in transmasculine individuals on T. So the approach again is open-ended questions. And I'm giving you options here again for your reference. But I always like to ask, do you have any questions about your sexual health? Because it sets the frame about why I'm asking these very personal questions. It's because we want to keep them healthy. And of course, we want to make sure that a person is having sex and that they're not asexual or, not having sex, so that we're not asking questions unnecessarily. And a very good question is, what are the genders of your partners, or what types of partners do you have? And the more you leave these questions open, the less likely you are to stick your foot in your mouth, and the more likely you are to really learn what's going on. So I just ask, what kinds of sex do you have? And sometimes you have to drill down and say, what body parts, be more specific, especially when people have gender diverse partners. You have to find out exactly what their biology is. And of course, you can ask about what are you doing to decrease risk of infections. We don't say protection anymore. That's considered a stigmatizing bit of language. And know that people use more than condoms and contraception now. People use pre-exposure prophylaxis. Several of my patients do sort of the post-COVID bubble approach, where they have a small group of people who they associate with. And so these are all ways to drill down. But a sexual history is a great way to ascertain who might need pre-exposure prophylaxis. And this is something I really encourage all of you. I'm sure all of you are familiar and use it sometimes, but really be an advocate for it, because we do need to get those rates of transmission down there. For your reference, I put all of the STI screening information on this slide. And again, for transfolk, remember, you just have to ascertain anatomy, sites of exposure, and sexual network. Very important. And education of patients really goes a long way. We assume people know these things, but they don't. So really telling people, like, receptive anal intercourse is so much higher risk. And that's why I want you to be on pre-exposure prophylaxis. Even needle sharing has a much lower rate of HIV transmission. And FYI, in the fine print, genital ulcerative disease increases risk of HIV transmission, but also BD, or as it's now called, vaginal dysbiosis, which is more common in lesbians and in transmasculine individuals on T, is a very powerful risk factor for HIV transmission. And although condoms are helpful, they are not infallible, and of course not used, not infrequently. And so we really want to double down on using our biomedical HIV prevention tool. We've got tool to use. And so again, this is for your reference. The thing I want you to take away from this slide is we can search PrEP in the smart sets and make this prescribing this very easy. Diagnosis code, and this is to honor Colby Rickless of previous grand rounds about not using stigmatizing diagnoses, is encounter for HIV PrEP. The ins and outs of the types of PrEP are there, but everything, including actually STI treatment and use of doxy PEP, are right in that PrEP smart set. So make that easy. And just a bit of a sobering fact here to keep those of us in family medicine in the loop. About a fifth of new HIV infections are in youth 13 to 24. Again, more often BIPOC people. Now, PEP also should be in your toolkit. And this is NPEP, non-occupational or post-sexual PEP. And it's very straightforward to use. This pocket guide I have a reference to below is everything you need to know, very complete if you ever want to refer to it. In our system, you can easily refer to the Madison Clinic, etc. But for folks who are not in our academic hallowed halls, it's ideal to have this very basic tool available. And recognize it's really true that if you are undetectable, you cannot transmit HIV. And this has really decreased the stigmatization for some of my long-term couples, really been freeing for them. And so that has a power in and of itself. But if somebody is detectable, knowing that getting them in for care is really important for prevention for the community as well. Doxy PEP is a thing. And for those of you not familiar with it, you're going to be asked about it. So it's not complicated. It's just 200 milligrams of doxycycline within 24 hours if possible, within 72 hours for certain, of condomless sex. That's the new phrasing for unprotected sex, right? We're not using that term. And it's only indicated for folks who've been studied in transgender women and men who have sex with men, including bisexual men, of course, especially those who've had a bacterial STI in the last year. That would be your cue to recommend it, but other people come in and ask for it, and that's fine. And it lowers the risk of chlamydia and syphilis by 70%, quite impressive for a cheap medication, and the risk of gonorrhea by 50%. But know that resistance to gonorrhea could become a thing and make it less helpful in that way. And to, be sure and counsel people to take their doxy with a big glass of water and to avoid sunny days like today. And then finally, for sexual health, remember contraception is important in this group. So some trans feminine people participate in sort of sex and may be fertile. Trans masculine individuals still very commonly assume that if they're on T and they're not having periods, they can't get pregnant. That is not true. Even on T for long periods, you can have ovulatory escape periodically. And you do not want to be pregnant when you're on testosterone because of the potential effects on the fetus. Bisexual, cisgender, assigned female at birth youth have 5 times the rate of pregnancy of heterosexual counterparts. And so again, always assess behavior, honor people's identity, but treat by behavior. So in summary, we've gotten lots of my opinions here today, and thank you for bearing with me on those. When we're looking at maybe a bigger part, and again, thinking about a curriculum for individuals, for ourselves and for our trainees, we really want to think about who comprises this demographic, what are their experiences, what health disparities exist, and what do we need to learn about those, and what contributes to them. Getting people into that adaptive coping mechanism approach, and then learning about the important elements of preventive care, including mental health related concerns and sexual health related concerns. And then I, again, don't have time, of course, today to talk about gender affirming care, but I think that should be a skill set that everyone has. But at the very least, you need to know to who to refer. So, summary slide about the connection with the patients. So creating rapport is especially important because patients do not assume the privilege that you understand their situation. Acknowledge trauma and loss, but don't be asking basic questions. Let your patient know you learned something, because that is the assumption that patients have, is that you don't know much. Of course, always ask for patients' input on treatment decisions. It's also a way you learn a lot about what the person's thinking is and about how to advocate for their health the best. Honor a patient who does not want to have certain types of exams. Encourage your patient to use their strengths to promote their health, and then take care to refer to specialists or treatment programs that are LGBTQ+ aware. And then finally, invite people to come back to care, because this is another thing that queer patients do not assume that they're really welcome here. And so if you just take that extra step, it will really help improve chances that you'll see them again. I want to just let you know that there's a fairly new online on-demand CME called AAP Pride in Practice. It's a 14.5-hour course that I just learned about and did recently, and it's pretty good. Here's a few other links, mostly about HIV and STIs. And then I will say, a lot of the up-to-date summaries, which are so brief, very brief, but still have a good review of a lot of these topics. So again, I'll have this distributed, and anybody who may not be on the mailing list for the Department of Family Medicine, let me know, and I'll be happy to send you a PDF. So like in the negative minutes that we have left, anybody who wants to stick around and chat, I'd be more than happy to do.
You're kind of at time, so maybe like somebody has a very urgent question you're sitting with.
Sorry, quick question. About PrEP, as a provider, do you officially recommend still using condoms, or how do you normally?
Yes, because there's other STIs and adherence to PrEP, although PrEP is very good, especially for men who have sex with men who are cisgender. We do not have that same degree of efficacy guarantee for cisgender women or trans people. And there's reasons to believe that you can never use the 211 in people who other than MSM, by the way. And people come and asking for that. I personally don't recommend 211 ever, because in my experience as a doctor, it's very hard for people to plan to have sex. And so that's what that particular prescribing requires. To answer your question.
Yeah, I can, I just on the website, so there.
Really, all you need to know is on that slide, and there's the link on that slide is a very pithy but more expansive thing. And then there's an entire course you can take through our local AIDS education and training curriculum that's at the end. That resource, very.
Thank you so much, and thank you for sharing your slides with us.
Thanks for your help, your time, everybody.